Hello everyone, it's Jihad Ali from Gankan University, Concept of Human Physiology 2, and supervised by Dr. John Tyson. And today we are going to talk about the cardiac presentation 1. So without further ado, let's get started. In this slide, I'm going to talk about the pacemaker activity of cardiac autorhythmic cells. As we know, there are two specialized types of cardiac muscle cells. The contractile cells, which are 99% of the cardiac muscle cells, do the mechanical work of pumping and contractions, while the other autorhythmic cells, which are small in number, do not contract but instead are specialized for initiating and conducting the action potential responsible for the contraction of the working cells. The cardiac autorhythmic cells do not have a resting potential. Instead, they display pacemaker activity, that is, the membrane potential slowly depolarizes between action potential until threshold is reached. At that time, the membrane has an action potential or firing an action potential. The first phase of the slow depolarization to the threshold is caused by sodium ions entry through a type of voltage-gated channels found only in cardiac pacemaker cells. Those channels are called funny channels. These unique channels open when the potentials became more negative, hyperpolarized at the end of the repolarizations from the previous action potential. Because of their unusual behavior, they are called funny. When one action potential ends, the funny channels open, the resultant depolarizing the net inward of sodium ions and regenerating sodium currents through these open channels, which are going to start immediately moving the pacemaker cell's membrane potential toward the threshold. The second mechanism contributing to this pacemaker potential is the progressive reductions in the permeability of the potassium ions channels. In cardiac autorhythmic cells, permeability to potassium does not remain constant between action potential as it does in nerve and skeletal muscle cells. The potassium channels that open during the falling phase of the preceding action potential is slowly close at the negative potential. This slow closure gradually diminishes the outflow of potassium ions down its concentration gradient. The results show decline in the rate of the potassium ion efflux occurring at the same time and simultaneously with the slow inward leak of the sodium ions through the open funny channels, contribute to the early drift toward threshold. The third shift happened in the second half of the pacemaker potential when funny channels close and transient calcium channels, one of the two types of voltage-gated calcium channels, open before the membrane reach the threshold, leading to large influx of calcium ions which further drift the membrane and bring it more closer to the threshold than close after reaching the threshold. Those three mechanisms are responsible for the pacemaker activity are called membrane clock mechanism. I have to mention there is another classic calcium clock mechanism which is spontaneous rhythmic local release of calcium from the sarcoplasmic reticulum, which increases the systolic calcium concentration. Each time the systolic calcium concentration rises, the sodium calcium exchanger, which is a plasma membrane carrier, repetitively transport one intracellular calcium ion out for every 3 extracellular sodium ions moves in. This exchange leads to net inward movement of positive ions in a process that gradually depolarize the autorhythmic cells to a threshold. Let's talk about the abnormal pacemaker activity, which is another aspect of the cardiac physiology. The specialized and contractile cardiac cells capable of auto-autorhythmicity lie in the following specific sites: sinoatrial node, atrioventricular node, bundle of His, and Purkinje fibers. In the heart, the fastest rate of action potential initiation are localized in the sinoatrial node. Once an action potential occurs in any cardiac muscle cells, it is propagated throughout the rest of the myocardium via gap junctions and specialized conduction system. Therefore, the sinoatrial node, which normally has the fastest rate of autorhythmicity at 70 to 80 action potential per minute, it drives the rest of the heart at this rate, and thus is known as the normal pacemaker of the heart. That is, the entire heart became excited, triggering the contractile cell to contract and the heart to beat at pace set by the sinoatrial node, autorhythmicity. If for some reason the sinoatrial node became non-functional, such as from the heart attack, the arteriovertical node assumed pacemaker activity. If impulses conductions became blocked between the atria and the ventricle, the atria continue at the typical rate of 70 beats per minute, and the ventricular tissue, not being driven by the faster sinoatrial node rate, assume its own slower autothermic rate of about 30 beats per minute, initiated by the Purkinje fibers. This situation is like a breaking down of a second engine arteriovertical node, so the lead engine sinoatrial node became disconnected from the slow third engine Purkinje fibers and the rest of the contractile working cells. The arterial cells continue at 70 beats per minute, while the rest of the cardiac cells proceed at 30 beats per minute. In this case is a complete heart block, which occurs when the conducting tissue between the arteria and the ventricle is damaged and became non-functional. In fact, the patient enters coma. When a person has abnormally low heart rate, as in sinoatrial node failure or heart attack, an artificial pacemaker can be used, such as an implanted device, arithmetically generate impulses that spread throughout the heart to drive both the atria and the ventricle at the typical rate of 70 beats per minute from sinoatrial node. Sometimes that an area of the heart, such as Purkinje fibers, became overly excitable and depolarized more rapidly than sinoatrial node. The slow engine, which is represented by Purkinje fibers, suddenly goes faster than the lead engine, which is represented by sinoatrial node. This abnormally excitable area, and called an ectopic focus, initiated a premature action potential that spread throughout the rest of the heart before the sinoatrial node can initiate a normal action potential. The resultant contractions called a premature ventricular contractions. If the ectopic focus continues to discharge at a more rapid rate, pacemaker activity shifts from sinoatrial node to the ectopic focus. The heart rate abruptly becomes greatly accelerated and continues this rapid rate for a variable period until the ectopic focus returns to normal. Such overly irritable area may be associated with heart disease, but more frequently may be associated with other reasons like anxiety, lack of sleep, or excess caffeine, nicotine, or alcohol consumption. Another aspect of the action potentials of cardiac contractile cells differ considerably from the action potential of cardiac autorhythmic cells. The rapid rising phases of action potential in contractile cells is the result of the sodium ions entry through the opening of fast sodium channels at threshold. The early brief repolarization after the potential reaches its peak is because of the limited potassium ions efflux through the opening of the transient potassium channels, coupled with the inactivation of sodium channels. The prolonged plateau phase is the result of the slow calcium ions entry through the opening of long-type calcium channels, coupled with the reduced potassium ion efflux on a closure of several tabs of potassium channels, while the rapid filling phase is the result of potassium efflux on opening of ordinary voltage-gating potassium channels, as in other excitable cells. Resting potential is maintained by opening of leaky potassium ions. In this slide, I'm going to talk about the ECG or EKG correlation to the cardiac events. So, the electrical current is generated by cardiac muscles during depolarization and repolarization spread into the tissues around the heart and are conducted through the body fluid. Part of this electrical activity reach the body surfaces, were detected using recording electrodes. The recording represents compression and voltage detected by electrode at 2 points on the body surfaces, not the actual potential. For example, the ECG doesn't record a potential when a ventricular muscle is either completely depolarized or completely repolarized. Both electrodes are viewing the same potential, so no differences in the potential between the two electrodes is recorded. ECG is a complex recording, representing the overall spread of activity throughout the heart during depolarization and repolarization. It is not a recording of single action potential and single cells at a single point in time. The record at any given time represents the sum of electrical activity in all the cardiac muscle cells, some of which may be undergoing action potential, while others may not be yet be activated. A normal ECG has three distinct waves formed. B wave represents atrial depolarizations, QRX complex represent ventricular depolarizations, T wave represent ventricular repolarization. Firing of sinoatrial node doesn't generate enough electrical activity to reach the body surfaces, so no wave is recorded for sinoatrial node depolarization. Therefore, the first recorded wave, the B wave, occurs when the wave of depolarization spreads across the atria. In normal ECG, no separate waves for arterial repolarization is visible. The electrical activity associated with arterial repolarization normally takes place simultaneously with the ventricular depolarization and is marked by QRX complex. The B wave is smaller than QRX complex because the arteria have a smaller muscle mass than the ventricle and consequently generate less electrical activity. At the following 3 points in time, no net current flow is occurring in the heart muscles, so the ECG remains at a baseline. So, during the atrioventricular nodal delay, this delay is represented by the interval of time between the end of B waves and the onset of QRX. This segment of ECG is known as the BR segment. It is called the BR segment rather than the PQ segment because the Q detection is small and sometimes absent, whereas the R detection is the dominant wave of the complex. Current is flowing through the atrioventricular node, but the magnitude is too small for the ECG electrode to detect. When the ventricles are completely depolarized and the cardiac contractile cells are undergoing the plateau phase of their action potential before they repolarize, represented by the ST segment. This segment lies between QRX and T. It coincides with the time during which ventricular activation is complete and the ventricles are contracting and emptying their blood. The ECG is a measure of the electrical activity that triggers the subsequent mechanical activity. When the heart muscle is completely repolarized after the T wave and before the next P wave, this period is called the TP segment, which represents the time when the ventricles are at rest and the ventricle filling is taking place. Let's talk about the abnormal electrical patterns are usually accompanied by abnormal contractile activity of the heart. The main deviation from normal that can be found through the ECG or EKG are abnormality in rate, abnormality in rhythm, and the cardiac myopathy. And here are my references for the cardiac aspect presentations. Thank you for listening and have a good day.